joining in this YouTube channel to revise the urology curriculum for FRCS exam preparation. Thank you for the trainee who has agreed to record this session so that it will be a good learning and revision tool. Your time starts now.
Yeah.
Today we are going to discuss the scenarios in BPH and, if time permits, functional urology. You have a 68-year-old gentleman presenting to A&E with a distended bladder up to umbilicus. How are you going to evaluate him?
I will review this patient myself in the emergency department. I will make sure that he is resuscitated and he is hemodynamically stable. I make sure that he was given some pain relief to control the pain if he's in pain. I will examine the patient. I will take a focus history from the patient. I will do examination in the presence of chaperone and arrange for some tests. So I will take a history from the patient briefly to know whether he has any lower tract symptoms previously, the duration, severity, whether it is mainly storage or voiding symptoms, any incontinence associated with that, any bedwetting. I will ask about any red flag symptoms like hematuria, weight loss, bone pain. I will ask about also his baseline sexual function, any constipation. I will check his past medical history and medication, especially diabetes or any neurological disease. I will also check any history of surgery or radiotherapy. I will check his drinking habit, smoking, and then I will proceed to rapid examination, mainly examining the abdomen, looking for any palpable mass or tenderness in the loin. I will check the palpable bladder, which is up to the umbilicus, according to the ED doctor. I will check the external genitalia, mainly looking for any possibility of meatal stenosis, phimosis, palpable nodule in the urethra, which is suggestive of urethral stricture. And I will perform, with the patient consent in the presence of chaperone, I will perform a digital rectal examination, looking for any lower limb edema as well. And I will do a focused neurological examination if there are suggestive symptoms. I expect that the ED doctors have already inserted the urethral catheter for the patient. If it is not done, then I will insert a catheter for the patient to relieve his retention, and then I can arrange for a further test.
Okay, this patient is asymptomatic and he just presented to A&E because of the tiredness and fatigue, and the relatives brought him to the hospital. He has no specific past medical comorbidities and is otherwise quite comfortable. He has no pain. He was catheterized, as you said, and he drained 1.3 liters of clear urine. You said you will concentrate on medications. What medications may lead to this situation?
Sometimes anticholinergic medication may precipitate acute urinary retention in the patient, and this could be in the form of anti-Parkinson medication, sometimes antihistamine. All of these, they contain anticholinergic component, which may cause constipation in this patient. Which may cause retention in this patient.
Okay, so how are you going to evaluate this patient further?
So, since the patient had a retention of more than a liter, I want to send the urine for urine dipstick, and also to check if there is any sugar, protein, and the specific gravity. I want also to do a blood test to check the kidney function. And I will counsel the patient about having a PSA test as well. I'm aware of the controversy about doing PSA in the acute stage, but I will have just an idea about the PSA, whether it is in hundreds or it is just mildly elevated due to the retention and catheterization. And since he's was having a retention with more than a liter, I will arrange for ultrasound of the kidney. I will observe his urine output to see how much he is draining per hour, and then I will take it from there.
Okay, his blood investigation shows kidney function is normal. Urine investigation dipstick taken when he was catheterized showed, say, 1 plus leukocyte, 1 plus RBCs, and ultrasound showed upper tracts normal and bladder is empty with catheter is in place. What are you going to do?
So my suspicion is that this patient is a low pressure chronic urinary retention. I will have a look. I will check his blood pressure in the lying and standing position, and I will check his urine output for the next 2 to 3 hours. And if he is not draining significant amount, there is no post-obstructive diuresis. Then patient can be discharged home, and then I will arrange to see him in the clinic in for sorry, I will I will discharge him with the catheter initially, and my plan is further assessment and discussion about the long-term management, and this will be done in the clinic in 4 weeks' time.
Okay, you said measuring blood pressure in lying down and standing positions. What is the importance of it?
Because if there is a difference of more than 20 millimeter mercury between the lying and the standing, indicated that the patient has some volume loss, and he need a fluid replacement, and he's at risk of having post-obstructive diuresis.
Is it common in low pressure chronic retention?
It's not common, no. Usually this will happen in the high pressure chronic urinary retention.
Okay, what is the pathophysiology behind low pressure chronic retention?
The pathophysiology is chronic gradual distension of the bladder muscle by an increasing amount of residual urine, which will cause secondary changes in the bladder muscle, including collagen deposition and fibrosis, changes in the musculature of the bladder, leading at the end into end stage failure of the detrusor muscle with painless chronic urinary retention.
Okay, so you have sending the patient with a catheter. How are you going to review him?
So I will I make sure that the patient know how to take care of the catheter, and then I will bring him back to the clinic in 4 weeks according to the capacity, and then I will discuss with the patient about the long-term treatment. I will inform the patient that my suspicion is that he has a weak bladder muscle, therefore the tension will happen. We are not sure whether this accompanied by bladder outlet obstruction or not. So I will arrange for this patient to have sorry, to have a urodynamic study for better counseling about benefit from surgical surgical treatment of the prostate.
You said it is due to decompensated detrusor muscle, and other than bladder outlet obstruction, what may be the reason?
It could be due to the detrusor muscle weakness, due to neurological disease, which happen in diabetic patient with peripheral neuropathy, patient with a previous pelvic surgery, previous radiotherapy, fractured pelvis. All these may lead to a form of levomotor neuron bladder dysfunction.
Okay, what are you expecting to see in urodynamics?
So in urodynamic, I want to see in the filling phase the sensation of the patient, and also to see the systometric capacity. And then during voiding, my aim is to see the voiding pressure. And we have a limit of 35 centimeter water if the patient is having a voiding detrusor pressure of 35 centimeter water or above. It means that he still have acceptable muscle function, and he will benefit from the surgery. And also I will look if there is any evidence of bladder outlet obstruction in the urodynamic.
Okay, what is the main difference between high pressure chronic retention and low pressure chronic retention in urodynamics?
Um, the main the main difference, I think that in the urodynamic, the high pressure may be associated with some detrusor overactivity, with reduced compliance, high intravascular pressure during filling, and it will be associated with high voiding pressure with low flow.
Okay. Okay, urodynamic shows that the bladder contractility is low. Otherwise, patient is able to void on command. His bladder capacity is huge, as I said, 1.3 liters. So how are you going to manage him further?
Sorry, what about the trusal contraction?
Say 40 mmHg.
40, sorry. Yeah, so I would take this as acceptable, the trusal muscle. And so I will counsel the patient about the prostate surgery, which may help him to be catheter free. However, I can't guarantee a complete bladder emptying after the surgery, and he may need to use self intermittent catheterization to facilitate complete bladder emptying.
Okay, we'll stop there. It's 10 minutes here. Good performance. There is no major concerns. Your opening gambit is fine. You are trying to cover the maximum points which examiner may be expecting. My only advice is try to stick to the specific scenario. That specific gentleman presenting with distended bladder up to umbilicus, painless, rather than trying to discuss the general low pressure chronic retention. So if you think in that aspect, you will bring the medications like is there any other medications other than what you said like antipsychotics or sympathomimetic drugs. You will bring a much more number of medications, while
Mm.
initially the medications which you brought in were more of like an anti-diabetic or few things only, and then on questioning you are able to bring much more medications like anticholinergic and other things, but still you missed antipsychotics, sympathomimetic drugs. So the medication history is very important in this scenario, so try to bring it to that scenario. I agree with you that doing a PSA is predominantly to see if the PSA is like in hundreds, which will give you a suspicion of possible prostate cancer. But that indirectly, prostate examination also will help you a lot. If it's really 100 means your DRE will show something. It is always preferable not to bring PSA measurement in a patient who is having catheterization. I completely accept your point, but in the exam, sometimes the examiner may misunderstand that okay, in spite of catheterization, this candidate wants to do a PSA test. The
Yeah.
easiest and safest answer is I will not do PSA in this context at this time since patient had retention and also catheter in place, but in due course I will keep PSA in my follow-up. Digital examination, I will try to rule out the prostate cancer. That is the gold standard answer. Otherwise, if you want to substantiate, you want to do PSA because you want to rule out something like more than 100 PSA, which will affect your treatment, you need to be very careful and you need to substantiate it. You are moving from a gold standard performance to a good performance. Sometimes it's good, examiners may accept it, but why to take any risk, isn't it?
Okay. Yeah, it's good. Thank
Yeah.
you.
And as you see, I started the discussion as a gentleman presenting with bladder distension up to umbilicus and also pain free. So take the clues and try to stick to the low pressure chronic retention, because you are slightly going into the general discussion of post obstructive diuresis, monitoring urine output, monitoring blood pressure, standing and sitting position. Nothing wrong in it, but the examiner should not think he is on and off bringing in all the features of high pressure chronic retention into the discussion, so they should not create a doubt. So try to make sure you are discussing only the scenario. If you are very particular, you can say I know even though the changes of blood pressure during position or post obstructive diuresis is not physiologically possible in a low pressure chronic retention, I wish to observe the patient. That is fine. Okay.
Okay. Yeah.
uh, at one point you are discussing a lot of things of HPCR in the discussion,
Yeah.
and then the commonest reason is bladder outlet obstruction. You are discussing slightly like it could be a primary bladder dysfunction or rarely could be due to bladder outlet obstruction. It is bladder outlet obstruction unless otherwise proven, and so take bladder outlet obstruction as the first reason, and other things like neurology, post surgery and all is very less chances. The main difference in urodynamics between the high pressure chronic retention and low pressure chronic retention is end micturition pressure. End micturition pressure is high in high pressure chronic retention. That is the reason why the reflux happens. As the reflux is happening, it results in increased intrarenal pressure, resulting in renal failure and that's what resulting in fluid overload, and that's the reason for post-obstructive diuresis once the patient is got catheterized. So otherwise your other urodynamic features were quite okay.
Yeah. Can I ask about the high pressure chronic retention? Because there is this loop diagram for the pressure in the high pressure chronic irritation. But my understanding is that the highest point of pressure is at the end of the filling. Is it at the end of the filling or at the end of voiding?
End of filling, normally men have good high pressure. That's what makes the patient to go to the toilet. Anyone, normal people, I mean. So once the pressure is there, once the patient is started voiding, the pressure should decrease, and the pressure will increase to empty the bladder because we are squeezing the detrusor, but the patient should not go above the competence of the vesico-ureteric junction.
Yeah.
Once that competence is breached, then only the reflex happens. So
Yeah.
normally what happens is at the end of micturition, the pressure should come down so that even if there is some urine reflexing back, it should come back to the bladder. In high
Mm.
pressure chronic retention during end of micturition, the pressure is high, so the urine stays in the ureter. Because urine stays in the ureter, urine stays in the pelvis, resulting in hydroureteronephrosis. That results in increased return pressure, decreased excretion, renal failure, fluid overload. There is a good BMJ article on just chronic urinary retention. You can search for it. And
Mm.
also there is a nice guidelines document. You can search for it in bnf.nice.org. Not the NICE website, it's a bnf.nice.org website. Very
Mm.
simple document. You have covered most of it, but it clearly says the end micturition pressure is the main difference between high pressure chronic retention and low pressure chronic retention.
Oh, okay.
Normally in the voiding, always the pressure will go up, then only you will create a good stream. That's physiologically normal. But even after completing the micturition, if the pressure stays high, that results in reflux and high pressure chronic retention.
Yeah.
Okay.
And my understanding is that since it is not a high pressure, then we cannot walk the patient. And maybe I don't think there's any benefit from Tamsulosin, but at least we cannot walk him while he's waiting for the surgery. We can teach him self-intermittent catheterization.
Yes. So treatment of low pressure chronic retention is different from high pressure chronic retention. In high pressure chronic retention, we can't walk. The patient will be on continuous draining bladder catheter. If the patient is so excellent and mentally very good in understanding, he can try intermittent catheterization if he doesn't like continuous bladder drainage. But end of the day, patient will be listed for surgery in 6 weeks to 8 weeks in high pressure chronic retention. In low pressure chronic retention, it depends upon the post void residue. If the post void residue is less than 500 ml, patient doesn't really require a definitive surgery. Patient can be started on alpha blockers, 5 alpha reductase inhibitors based upon the prostate size, the same principles of LUTS treatment, and patient can be monitored. Alpha
Mm.
blockers will help in improving the urine outflow. Intermittent catheterization is also equally good. We can talk the patient. If the
Okay.
patient's post-void residue is more than 500 ml, patient needs long-term follow-up and observation to make sure they are not ending up in another episode of low pressure chronic retention or high pressure chronic retention later. Usually it's very rare for those people to end up in high pressure chronic retention. If the
Okay.
patient doesn't like intermittent catheterization, there is an reason for bladder outlet obstruction surgery. But in low pressure chronic retention, since the bladder detrusor is already decompensated, there is no assurance that bladder outlet surgeries like whether it's a TURP or holmium enucleation of the prostate or any anatomical enucleation of the prostate will result in a good detrusor recovery and normal voiding. So bladder recovery, only the time will say. While in high pressure chronic tension, TURP or a good anatomical enucleation of prostate will give very good result. We know the detrusor is working. Because of the detrusor is working only, in the end micturition, the pressure is maintained high, resulting in high pressure chronic retention. So in high pressure chronic tension, in fact, you don't have to even do urodynamics. The presentation of hydronephrosis, renal failure itself is a sign of good detrusor function, and they will come out very good with surgery. While in low pressure chronic tension, we need to do urodynamics to make sure that the detrusor pressures are nicely documented. We should warn the patient about the hypocontractile detrusor, which is not recovering in the future follow-up, and need for intermittent self-catheterization, or if the patient toxicity is not allowing a continuous bladder drainage in spite of surgery. So we need to warn the patient. That's the main crux difference between low pressure and high pressure chronic tensions.
Very good. Thank you very much.
Okay. Can we go for another scenario?
Yes, please.
Okay. And in these scenarios of retention, do not bring in any fancy newer modalities like Eurolift, Resume, iTind, Aquablation. Number one, they were not tested in this situation, even though we have papers to support Eurolift as a role in chronic urinary retention or acute urinary retention predominantly. We know the multicenter UK based study. The patients selected were very close to group with a post-word residue less than 500 ml. So it's very difficult to bring out of a blue moon one study and substantiate your finding. It's always better to go for gold standard TURP or anatomical enucleation of the prostate using any energy, whether it's bipolar, thulium laser, or holmium laser, doesn't matter.
Yeah, thank you.
Okay.